What's the whole notion about what do we know 30 years later or 40 years later after we have studied it to death, okay? What is actually happening with premenstrual dysphoric disorder? So we know that you have to have a hypothalamic pituitary gonadal axis that works. So you have to have a cycle. You have to have a woman who has mainly regular cycles, and that is the trigger. We also know, and I already told you about this balancing act, that there is a reciprocity between the HPG axis and the neurotransmitter systems, which are the substrate, which modulate mood and anxiety and everything else. So the idea was you can either abolish the trigger, okay? You can castrate women. And actually that was suggested and done. Until 30 years ago, a woman in her mid-30s would come to a gynecologist with severe PMS, and they would do a total oophorectomy, hysterectomy. Okay? That's one way. Okay? We're not doing this anymore. The next thing is you can actually castrate pharmacologically. Okay? You can give women treatments that will abolish the cycle. Again, do you want to introduce at age 26 or 32 early menopause with all the risks that we know now about what can happen after menopause? No. So the idea was, and that's what we were working on it for many, many years now, to find something, okay, that will address this reciprocity between the neurotransmitter system and the HPG axis without touching the HPG axis, but helping the neurotransmitter system. And the culprit was identified as serotonin. And the idea was that in a small proportion of women, and I'm talking about maybe 5 to 8% of women in the reproductive years with regular cycles, in that small proportion of women, okay, the withdrawal of estrogen premenstrually coincides with also a reduction in the serotonergic system, and their system views this as a catastrophe, okay? If I can paraphrase it, okay? And that's the big irritability, dysphoria, anxiety, tension. So why not trick the system, okay? And tell the system, you're not losing serotonin. I'm gonna give you an SSRI. I'm gonna give you an SSRI just for those days, okay? So that in the synaptic gap, that system will not feel the withdrawal, and voila. How did that actually happen? That was not easy. When the SSRIs came on the market, we were the first in the world, okay, to actually try Prozac on women with PMS. We did a pilot of 10 women. We gave them Prozac continuously, all the time, okay? And after 3 cycles, the men called up and said, whatever you did, don't take it away. Okay. So we knew, and we selected a group of women who were severely burdened and affected. We went to Eli Lilly and we said, we have to do the real study. We did the real study, and we were the first to prove, and we published in the New England, that actually an SSRI works. The biggest surprise of that study was that we did not have to wait 6, 8, or 12 weeks for the antidepressant to kick in. We saw results within days. That triggered the notion that we're not talking about the same mechanism of action of the SSRIs as in depression. This is a different mechanism. We need much smaller dosages, and we can give it only for the days when it's necessary. And then we had to go to the FDA and declare that PMDD is distinct from other mood disorders, and we were able to do that. And we also had to show that we're not talking about all the other conditions that might display as premenstrual exacerbation, but we're really talking about something that is on-off, that has a symptom cluster that is unique, and we also had to establish that there is a burden of illness, and that the burden of illness is similar to any other mental disorder, but it's only affecting a woman a few days a month. These are the women who came and said, 3 weeks a month, I'm normal, I'm perfect. All of a sudden, I don't know who I am. We then went and decided to actually look whether what we proposed at the time to be DSM-4 criteria for PMDD, whether we can improve on that. And lo and behold, we have developed a tool, and what we have done, we have actually ambushed 508 women standing in line for the flu vaccine. And we asked them to complete the questionnaire that we developed, okay? And remember I said that anywhere between 5 and 8% of women of reproductive age qualify for PMDD, and yes, we saw the same thing. But if you reduce 1 or 2 criteria from those DSM-4 criteria, you actually find that there is another group of women who have severe enough PMS that does affect them, okay, which is very important to remember. But it's not 80%, like the old literature was saying. The next question that the FDA asked was, well, all the studies were done on women who were 18 years and older. We don't believe you guys that it actually happens in the younger age group. So we ambushed 511 kids in high school, girls, adolescent girls, between the age of 12 and 17 in 3 different centers. We were showing that actually PMDD was even higher, was at 8.6%. Severe PMS was the same. What was missing? The burden of illness. If you're not married and you don't have a job and you don't have 1.5 kids at home, the irritability that you experience, okay, the reciprocity with your environment, your psychosocial entourage is not as affected, okay? So these girls will actually not seek help, okay? We only had 4 girls in that group who came for help to the clinic. But yes, we were interested in the functional impairment and the burden of illness, and as you can see, it was much the same in the adults, both in the PMDD and in the severe PMS group. The whole notion that serotonin works is coming actually from 2 hypotheses. One that links the interface with the ovarian hormones peripherally, and the other one that talks about the gonadal hormonal steroids coming directly from the brain, mainly from progesterone, that serotonin has a positive effect on the breakdown to allopregnanolone, which is actually the benzodiazepine of the brain. And of course, if serotonin is involved, if you increase the levels of available serotonin, the end effect is positive. This is the only diagnostic category where you have 51 studies who are all positive with serotonergic agents, okay, treating open label or double-blind controlled studies showing that all serotonergic agents work for PMS, PMDD. They don't work for all women, okay? But in all these studies, there was a statistically significant effect of the drug compared to other comparators, even the tricyclics, or to placebo. Let me move on to pregnancy. I said I will sort of try and cover a little bit of everything. I already told you how common depression is, but people say, oh, just get pregnant, everything will be fine. That's what grandma used to say. That's not true, okay? When I say 10% of women have depression during pregnancy, this is an underestimate. There is 2 UK studies, one shows 17 and the other one just recently published shows 22% of women that were screened had depressive symptomatology. Obviously, we know that it happens a lot also in the postpartum period. The average in most studies is around 15%. And last but not least, it is a recurrent phenomenon. Why is it that only in the world, okay, only 0.8% of childbearing women are being identified? And why is it that so many women receive inadequate treatment? And why is it that we all have such a hard time with compliance in that population, despite the fact that we now know how much this will affect in terms of maternal and infant morbidity? Stress. So stress is not good for you during pregnancy. Is this something new that we did not know? 300 years ago in Japan, the Japanese don't talk about 9 months of pregnancy. They talk about 10 menstrual cycles, which is 40 weeks. So you don't have 9 women here, you have 10, okay? For every 4 weeks of the pregnancy, here she finally is going to have the baby. For every 4 weeks, you have to tend to another flower, okay? And if you will do that, you will not suffer anxiety or stress or depression. Wouldn't that be nice? So, what is it about depression during pregnancy if you don't treat it, okay? And there's a long list of what will happen, and number one is that if you don't treat it during pregnancy, the chances that this woman will actually be postpartum depressed are extremely high. It's probably the best predictor, okay? And there is many more other things. In big cities, they will use more drugs and alcohol and smoke more, poor self-care, non-compliance with prenatal care, a lot of obstetrical complications, preeclampsia, negative effect on bonding. We think that bonding starts when the baby is born. No. Bonding usually starts anywhere between 12 to 16 weeks of pregnancy, okay? This is when women start to relate to that baby. I have seen women 7, 8 months pregnant who come to the clinic, pregnant, talking about it. No bonding whatsoever. This was all a mistake. I should have never done this. Okay. So, and last but not least, although extremely rare, there are cases of suicide. More frightening is when you see a woman in your clinic and she says, I'm going to kill myself the minute the baby is born, not before.